Thanks, Cormac. Hopefully I'll be able to provide some answers today. I suspect I'll leave you with more questions than answers when we get through all this. First of all, it's an honor and a pleasure to be here today, and I do want to thank the organizers, Cormac, Patricia, Patrice, John, and the countless others that have put together. I think it's been a fantastic meeting, and they really do a lot of the work unseen behind the lines. Cormac wanted me to talk a little bit about incidental Chiari malformations in kids. And I'm going to give you our experience really in the last 15, 16 years. And I'll give you some other insights as well, and hopefully it'll make it a little bit clearer. We do have in the past support from ASAP for some of our work, so we do want to acknowledge that and are grateful for their help. And I think it's fair to say that Chiari malformations really are an evolving paradigm. I think everybody in this room knows that, and we often end up with more questions than answers. I do want to disclose that we are Badger fans, having two sons in Wisconsin, so I don't have the graphics that you saw from Benny Iskandar, but and we are playing Michigan next fall, unfortunately here, but we'll be here for that. Anyway, I think we all know that the Chiari malformation, we've got all kinds of numbers, 1s and 1.5s and 0s, and God forbid, maybe a 1.75. I think it reflects our discomfort or maybe lack of understanding what it really is. And I sometimes think we look at this as a radiographic or neuroanatomical feature, and as you all know in this room, it's a lot more than that. And you've heard countless times today and yesterday the definitions are poor, the 5 millimeters, all of these things are real, and I think most of you already know that. If you don't know it, you know it by now. But it may also be possible that perhaps this reflects a different disease process depending upon the age of the patient versus a continuum. And we also know that everybody in this room, the presentation, the Chiari presentation, is different for every single person. And we can kind of lump in and say this is what we normally see, but we don't normally see anything. And I say to my patients and their families, everybody's has their own textbook when it comes to Chiari malformations. And then that's part of the problem for the clinicians. What's clinically relevant or significant, what can be made better versus just saying what an x-ray shows. And we all know, again, the symptoms are variable, and you've seen this list before, and I think the thing to take home from this is fill in the blank on the bottom. Because really, a lot of folks have all kinds of stuff that are on the net or not on the net, but the bottom line is it's significant or meaningful for them. And the presentation's the same way. I mean, certainly we see plenty of scoliosis, and we see syringomyelia, and we see the folks with cranial nerve issues and pseudobulbar palsies and all that sort of stuff. But again, very, very variable, and obviously very pertinent to the age of the patient and also how they present. So we have lots of kids out there, and I'm going to focus this on pediatrics, but I think it applies to the adults to some degree. Lots of folks out there with headaches, dizziness, fatigue, malaise, all sorts of things. And as you now know, the likelihood of having an incidental Chiari is relatively high. People throw out that 1% number, maybe a little bit higher, and we'll talk about it more in a second. But when are they connected? And you've also heard some nice talks and discussion about idiopathic intracranial hypertension or pseudotumor or hidden or occult hydrocephalus. Is that the 800-pound gorilla? And I think there's more to the story than we perhaps recognize. And what is the significance of Ehlers-Danlos and so forth? And again, for those that don't appreciate or understand this, and I suspect that's very few people in the room, this is a ligamentous laxity situation. It often is in concert with Chiari malformations, and these patients often have mild to moderate degree of tonsillar herniation. But what's always striking to me as a clinician is that their symptoms and their presentation is often out of proportion to what we see in the x-ray. That doesn't mean it's not happening, it doesn't mean it isn't real, but you sit there a hard time trying to juxtapose an x-ray and the patient's presentation and or their exam. And we also know patients with connective tissue issues in ligamentous laxity type of situations, whether you want to call it EDS or not, they sometimes can be very similar to patients with significant compression of the brainstem or other types of neural structures. So it can be very concerning and very worrisome even for the neurosurgeon. So this really is an umbrella term of connective tissue disorder. It's very often familial, it's joint hypermobility, skin hyperextensibility, and not uncommonly cardiovascular dysautonomia. These are the folks that come in with the arrhythmias and the bradycardias and all sorts of things that are seen the cardiologist ended up with a negative test. Folks with this condition frequently have generalized pain, fatigue, and not uncommonly, at least a third of these patients have headaches. And again, we see patients with this, with Chiari malformations very frequently. The prevalence, the significance is still unclear, and hopefully it'll become clearer over time, and there really is not a lot out in the literature. And you've already seen this, and I ask my patients fairly early on when I'm looking at their Chiari issue, how many of these features do they have? Because it often explains a lot of the situation that we have. Now, it's also interesting when you look at Chiari malformations, and this is part of the incidental kids as well, there are a number of other associated conditions, and it's not just EDS. These kids are prone to have NF. We see that association. A lot of these are midline issues, tethered cords, patients with basal invagination, metopic ridging. The folks in Alabama wrote this up not too many years ago. It's interesting that a lot of these midline issues are also frequently accompanying the Chiari malformations. And so is this really a functional of a larger genetic or syndromic overlay or some type of genetic common shared loci? Hard to say. Again, not a lot of literature. You've heard some groundworking stuff they're doing at Duke, and you know that we're making progress in this area, but it's still fairly early on. Now, when we looked at our patients a couple of years ago for family history, and this is family history where they had a clinically positive diagnosis, they had an x-ray or something to support this, we found that roughly 8% of all of our patients had a positive family history. And we looked at that for the incidentals, it was actually 6%, and it was a bit more for the symptomatic. The only difference for the incidentals, or certainly for these type of patients, they seem to have more frequent headaches if they had a positive family history. The other thing I want to point out is it's not uncommon, and I suspect some of the pediatric neurosurgeons get this as well. You'll get a family with 5 kids, and 4 of them have already had the MRIs, and 4 of them have some manifestation of Chiari malformation. And mom or dad has had surgery, or mom's had surgery, and so forth. What's amazing to me is 4 people, 4 very different stories. And some kids have the worst looking MRI you've ever seen. They look great clinically. Other kids' MRIs don't look too bad, and they look like a disaster. So it is a very variable presentation. Again, it demonstrates, as we all know, that this disease is all over the place when you look at it. And again, the question for that is why? Is it that there are many different etiologies? You've heard all the possible reasons why you might have a Chiari: pressure, small posterior fossa, CSF outflow issues and leading to syringomyelia and whatnot. And I suspect, again, it's the different people holding the elephant and feeling different parts of it and saying, well, it's an elephant, but this is the trunk and this is the tail and so forth. And it also raises questions that maybe we're trying to define something that is not the same across the board, and the etiological basis is really where the money is, and perhaps more importantly, where the answer is in the treatment and so forth. So we actually looked at this a couple of years ago. One of our residents looked at the posterior fossa volume and looked at the extent of decompression, how much bone was removed, how big did we make the posterior fossa afterwards, and correlated that with the outcome. And the green is the degree of folks that have improvement of success. And you can see the more volume, the more space that was created. In this group of patients, it significantly was correlating well with the beneficial outcome. We're also going to hear from Mark Quigley shortly. Mark's going to talk to you about all types of things with CSF flow, and is this the holy grail, and trying to figure out what the flow dynamics are. And again, it certainly may help to explain some of the issues with Chiari malformations, but unfortunately, it won't give you all the answers. But it may very well be a very important piece of this. And as you heard earlier from some beautiful talks yesterday, we don't have an easy way of quantifying this. You can say, yeah, it looks pretty bad, it looks pretty good, but it's hard to be able to give a number. And obviously, we all love numbers to try to come up with objective manifestations. So what is the significance of an incidental Chiari? Is it really incidental? Is it an early manifestation of an adult disease? What's the risk of going on to requiring surgery? We've heard a lot lately that it's not a big deal, it's not a problem, probably don't have to worry about it. What's the likelihood of this changing over time? Again, the follow-ups in this are relatively short, so it's hard to really know. Are these patients different from the symptomatic patients? This is a whole different cohort, or are they just a different subset? And how does the age affect the presentation? So when you look at age, this really is a reflection of is it really a reflection of different causes of the Chiari malformation, or is it just part of that continuum that you're just having to be getting a snapshot in time? When you look at someone that's out 30, 40 years, there's a lot that goes on over that time frame. Do the younger kids differ from the older kids? And the adults a delayed presentation of a congenital problem, or is that a whole different concept of disease in itself? So we looked at our kids, there's not a lot in the literature, but when we look at our kids, the bars to the right, the orange bars are the teenagers, late teenagers, and the purple bars are the early teenagers. And we saw that with the older kids, apnea, excuse me, extremity symptomatology, neck pain, scoliosis, and syringes or syringomyelia all increase as these kids get older. When we look at this also, when we look at the degree of tonsil herniation, as you get older, much higher likelihood of having tonsils more than 10 millimeters below the foramen magnum. Much higher likelihood, statistically significant, of having syringomyelia and subsequently scoliosis and so forth. If we look at it here, you can see that the younger patients are presenting more often with bulbar symptomatology, brainstem symptomatology. And as they get older, it becomes less of an issue. But as they get older, the syrinx, the degree of tonsillar herniation, gives a more likely chance of having syringomyelia and subsequently scoliosis and so forth. And again, we look at snoring and bulbar symptoms and gait abnormalities much higher in the little kids than it was in the older kids. So when we look at this, it would appear that the younger patients present usually with brainstem symptomatology, small spaces, whereas the older kids, the tonsils are lower until they get to be 20. You heard that from Cormac earlier, and then they seem to ascend. But they're also more likely to see a large syrinx and, not surprisingly, scoliosis to go along with it. Is this two different diseases? Is it a different manifestation? We still don't know. So how often is Chiari found in the real world? And I'd like to point out I showed you Washington, D.C. to represent the real world. Cormac and Joe Pyatt put together a very nice paper, just recently came out in Pediatrics, looking at incidental findings. And they pointed out that MRI scans are ubiquitous, as you know. The number of scans are now twice in the United States what they are in the rest of the developed world. And the use has quadrupled from 96 to 2010, about an increase of 10%. Why? They're available. People are demanding them. And then there's also defensive medicine. Well, let's just get an MRI and we'll see. And I'm not saying that's wrong. Maybe we're actually the right place. Maybe everybody else is underutilizing it. But Cormac pointed out nicely that there's lots of incidental findings out there, and that's maybe great for the radiologist. But when is it real, and when does it mean something, and what do you do about that? We see brain tumors and so forth. I highly recommend finding this paper. It's in Peds. It was just published. It's very interesting where we're going with all this. So as you heard earlier, the natural history is still unclear. People throw out a 1% incidence. I think Cormac did this nicely this morning. He said, well, what about the age of the patient? And in their paper, they said actually it's as high as 3.6% having an incidental Chiari. Now, you might also argue that little kids perhaps are getting more MRI scans than mid-level folks, although the older folks, as you pointed out earlier, perhaps are even higher. But it's a real number, and if it's 1% or 2%, you know, that's not a huge number, but that's a big number if you look at the demographics of the country. Now, what was interesting, and I think is still true even though it's been over a decade, is when you ask neurosurgeons in general and polled them, what would you do with an incidental Chiari malformation? There is no set routine. There's no standard or protocol that people follow. And I think that's still true today, although people are generally conservative, appropriately so. Nobody has, this is what you do and this is why you do it. And the reason for that is we just don't have any information. We don't have any long-term data, and the data we have is often not as clean or as helpful as you would like to see. You've already seen this earlier today. The bottom line is this is a study that came out of Rome, and they looked at patients a long time ago, and they had 11 patients that had minimal symptomatology and 11 patients incidentally found with Chiaris. And I want to point out here, sure, most of the kids did well, and that's a good thing. But there were 5 patients that deteriorated over time, and 3 of them did end up having surgery. So it's not a completely benign thing. Again, another paper from Rome out of DeRocca's group, same issue. Most of the patients are fine. Occasionally, patients fell apart, pointing out that it's something that the patients generally do well with, but you can't blow it off and say, well, call me if you're having a problem, it'll be okay. You've seen this already. Cormac and his group here in Ann Arbor looked at this. And again, what I found interesting was, yes, most of the patients did fine, but 9.5% to 10%, actually that number's off. I think he said he had 16 patients. 10% of these patients did eventually need to have surgery. So like everything else, it depends how you look at this. And this is a paper that came out of Miami, Dave Sandberg's group down there. And again, Cormac already talked about this, but the bottom line is majority of patients do well, but some don't. And that, of course, raises the question, who are those patients? So nowadays, I think most neurosurgeons, pediatric neurosurgeons, probably adult guys too, would support a conservative approach. Just because it's there and the kids are doing fine, you don't necessarily operate, but you do need to follow these patients. We do not have any prospective studies. We have some prospective data I'll share with you in a second, but they're all retrospective. And I'll show you why that may or may not be a good thing. And certainly when you look at the management of the Chiaris and the management of syringes and so forth, and how long do you follow these patients, it's all over the place. So it's hard to get anything meaningful from what's already out there in the literature. But as I said earlier, most folks would argue conservative management, but there is going to be that 9-10% of patients that may get into trouble. I'm going to get past this. So when we look at all of our patients, we've got close to 800 patients at Children's. In that group, more than half are incidental. We obviously do a lot of MRI scans, maybe too many, maybe not enough. I'm not going to sit here and judge that. But when we look at those patients, I'm going to compare this at the end. Most of these patients went to surgery because of progressive symptomatology. The average age was 9. You do see we have more boys than girls, and the overall numbers, although this works itself out when you look at the surgical candidates. And roughly 10% of these roughly 83% of these patients get better with surgery, but 10% come back, or 9.3% come back. And here's the problem. This isn't benign. 18% of our patients had some type of complication, and we consider a pseudomeningocele a complication because the kids aren't happy, the parents aren't happy, and sometimes they're back in the hospital. To me, that's a complication. So when we look at incidental, we use 5 millimeters. It's not perfect, but that's what people use. It's a common metric, so that's what we use. And these were kids that got scans for reasons completely not connected with a Chiari issue. Even when you ask them and look for subtle things, this was car accidents, and I'll show you what the reasons were in a few seconds. It really was unexpected. It wasn't that somebody wasn't paying attention, doing a good job. It was, wow, wonder where that came from. And we excluded lots of stuff. If you had occipital headaches, if you had spasticity, if you were coming in for scoliosis workup and so forth, that just threw you out because that really wasn't a true incidental MRI scan. And it's interesting when you look at this slide, and this is unfortunately bad for the statistics because a lot of this is in the last 10 years or so. And it is interesting to me that although we were getting more and more each year, roughly 50, it seems to we seem to be going down. And that's a good thing because I think, frankly, it means that either the pediatricians are addressing this directly in the office, and we get most of our patients from the pediatricians, or perhaps the radiologists are being a little less aggressive in calling it low-lying tonsils, Chiari-like, and all that sort of thing. But we do get almost one kid a week off the street diagnosed with a Chiari malformation that's incidental, not symptomatic. So I'm going to just show this. This is all of our incidental patients. And you can see we're close to 500 patients. And 12%, when you take everybody, every comer, ended up getting surgery. These are kids that came in without a Chiari problem, but more than 10% got surgery. And our follow-up in this is roughly 4 years. But what's interesting is when you look at this and you compare it to the prospective, which we started after 2008, the rate is much different. And this is the benefit, or at least the honesty, of prospective data versus retrospective data. We've got an 8% rate when we look at prospective, following the closer rather than trying to figure out, did this mean this, this, and that. And that was still felt to be statistically significant with groups that were matching up nicely. They weren't different groups of kids. So when we look at the prospective kids today, this is data from 2009 to the present. We've got 274 patients. So it's a little bit more than half of all of our incidentals if you throw out all the retrospective patients. You can see the age of diagnosis is 7.5. We've got 54% of them with follow-up more than 6 months. There are patients that come in with a diagnosis of incidental Chiari that say, that's nice, I'm out of here. Or perhaps they go elsewhere, or maybe get operated on elsewhere. We offer them routine follow-up, and I'll share with you how we do that in a little bit. But because of all the patients towards the end of that graph, our follow-up is relatively short. It's only a little over 2 years. 10% have syrinxes, and in this group of 274 patients, 19 or 7% eventually required surgery. So these are patients that had surgery even though they came in with an incidental finding, and the average time to surgery, which is fascinating, is only 4 months. And I know people are going to say, well, maybe they're not as incidental as you think they are because of that. These are the reasons they get scanned. Trauma obviously is up there at 15%. A lot of seizure kids getting scans, you can see 15%. Non-specific kind of vague headaches, 9%. Frontal headaches that were not felt to be related to Chiari was 7%. Developmental delay and neurobehavioral, and we have a lot of kids in protocols, sickle cell, neurofibromatosis, that get their scans once a year. So there's a lot of scans. I suspect this makes a lot of money for the hospital. Nonetheless, when we look at the reasons why they went to surgery in the prospective group, 2/3 went to surgery because they had a syrinx at presentation. And if we find somebody that has an incidental Chiari and they have a legitimate syrinx, we feel that's an indication for surgery. And that's hard to convince a parent. Well, your kid looks great, he's doing fine, but he was in a go-kart accident, we need to go ahead and operate on him, but we're usually able to do that. What is interesting is 1/3 of these patients, 6 of the 19, went on to develop symptoms they never had. I don't think it was power of suggestion, but these are new issues, and one of that group went on to develop a syrinx they did not have in the first place. If we look at the retrospective data, we actually had 5 kids present with syrinxes, and I think Cormac's group saw that as well, that didn't have it but developed it over time, so maybe we're in the right place at the right time. So when the patients with syrinxes, half of our patients that had a syrinx in the whole group did not get surgery. They were followed conservatively or went elsewhere. But again, as I said earlier, we had 5 of those 28 patients of all the kids that went from the incidental group to get surgery because they developed a syrinx. 1 was in the prospective group, 4 were in the retrospective group. And our approach for the prospective incidentals was that about half of them would get an open operation, the blue plate special, so to speak, that you've seen already. But about half of them got bone only. And I'll share with you why we do that and how we do that. 58% improved, 42% stayed about the same. Their syrinxes didn't change very much, and that's open to debate. No one to date has had repeat surgery, although we follow them very closely. And our complication rate is 16%. That's a real number. You'd prefer to be low single digits, and one of the 19 was an infection, and 2 were pseudomeningocele that got better, but still required a readmission. So how do you tell who's going to fall apart? What do you say to a parent when you're telling them something they've never heard of? The kid was fine until they were in a car accident or had the seizure. How do you tell them, well, we're going to follow you forever, we're going to follow you for so many years and so forth? And when we looked at the factors that were associated with going to surgery if you were found with an incidental Chiari malformation, they were a positive family history, they were Chiari 1.5s, and they were patients that had tonsils greater than 10 millimeters below the foramen magnum. And I didn't put it in blue, but if you were less than the age of 5, there was a slight increase in going on to surgery. Factors that weren't involved, it didn't matter if you were a boy or girl, it didn't matter if you were over the age of 5, and it didn't matter if your tonsils were in that gray area of 5 to 9 millimeters. And as we've talked about these numbers, I always say to my patients, it doesn't matter how low your tonsils are, it's how tight it is, and this may be a better way of defining this, as you've heard earlier. So if we look at this, if you certainly come in as a child under 5, a 1.5 Chiari malformation, or even worked up for neurobehavioral issues, you do appear to have a higher likelihood of going into surgery. And we worry about those kids a little bit more and keep a better eye on them. So when we look at the time to surgery from diagnosis, and this is something I still don't have a good idea of why it's happening, and I'm open to suggestions. If we look at all incidental patients with a 4-year follow-up, 17% of these patients got surgery in this retrospective and prospective group. You can see most of them fall apart fairly early. And that seems to go against the concept of this being truly incidental. Why would they fall apart 6 months, 12 months or later, and so forth? When you look at the prospective kids, short of fall because of the way we're seeing the patients towards the end there, only 7% of these kids get surgery over time. And again, they seem to fall apart certainly within 30 months, 2.5 years, but even earlier they're falling apart. And it's not clear why, if they really were truly incidental, they end up getting surgery. Now, I'm sure there are a lot of folks who are thinking, oh, you neurosurgeons, man, you must be trying to get more work and so forth. I can guarantee you that is not the case. But it's a fair question. So from a surgical standpoint, we only operate if they have intractable symptoms, and the symptoms need to be referable to the Chiari, so intractable occipital, exertionally related type of headache, where you can't go to school, you can't play sports, and so forth. We have a lot of kids that have on and off symptoms, but we don't necessarily do anything to them surgically. Clearly, any sign or evidence of neurological compromise, brainstem injury, and so forth, obviously will buy you an operation. And I think if we see someone with legitimate syringomyelia, not an expanded central canal, we have lots of kids that we follow for that, we would feel that surgery was appropriate. And then there's the argument, do you open the dura or not open the dura? And you've heard a lot in the last 2 days about the controversy and the discussion, and hopefully we're getting closer to an answer. It's still very controversial, and we generally try not to open the dura if we have an intraoperative ultrasound that says to us, wow, things look a lot better. Now, Corinne Morasko yesterday said she always opens the dura for syringomyelia, that she's been burned too many times, it looked good on the ultrasound, but at the end of the day, the kids came back. We've had some experience with that. And I think some of the nurses here have had the same experience. But if we see in the ultrasound that as we're decompressing the tonsils, and the tonsils go from this pointed, tight, snug space to a rounded, more room, elevated, more CSF, less pissoning, we have a number of parameters we follow, we feel we've done the job by taking off the bone and the outer leaf of the dura. We'll call it a day, even with the syrinx. Although if you look at our failures, and I'll talk about it in a second, the ones that did fail were more often the whole cord of the syrinxes that cover the entire spinal cord. And again, lots of approaches to this. You've seen some of this already. It is interesting. There's lots of literature out there about the benefits and the disadvantages of doing an open decompression, the duroplasty, the stenting, and all those sorts of things. And the folks up in New York just published this the other month, where they had 156 consecutive bone-only decompressions. And they claim or report that they had greater than 90% improvement in their symptoms, no complications, but they had a 9% reoperation rate, which seems to be a pretty standard number, about 10%. And when they saw it, Richie Anderson himself told me this, it's usually the kids or the patients that had lower tonsils, again, a different subset of patients. When we look at our surgical failures, and we're presenting this at our national meeting in October, we had 9.3% of all of our patients required a second operation. And when we looked at the bone-only decompressions, that was 14%. We looked at the duroplasty and doing all the work that you've heard about, it was 7%. It would imply that there's a trend towards less failures with the open operation, but statistically, it wasn't significant with a P of 0.11. We'll see where that goes. But it is interesting when we looked at these kids second time around and did open the dura and did look at the outflow of the CSF at the foramen magendae, 17 of the 19 were socked and scar. It was not a surprise that they didn't get better with their syrinxes. And actually in that group, half of them required a stent because we didn't think that scarred space is going to stay open, or we thought as we manipulated, we'd get into trouble with some of the blood vessels and so forth. And we didn't see a difference between either group, between the open versus the closed for the scarring and so forth. So our complication rate's about 16%. With the prospective, it was as high as 23%. And these usually were plumbing issues. These were CSF collections, occasionally drainage. And I know this is controversial. It was at the dura not closed. This is 5 different neurosurgeons over 15 years, all well-trained, all doing a good job. I think it's a bit more than technique. And I've had people say, you guys aren't doing a good enough job closing. I can tell you, I've spent hours closing the dura, longer than I did decompressing the Chiari, and they still leak. So I'm not certain. The answer is somewhere in the middle on that. And our outcomes in this particular group, the prospective, was improved 58% of the time and stable the other time. We were obviously watching these kids closely. So just to finish with an example, this is a 13-year-old boy in a go-kart accident, has a CAT scan for concussion. Lo and behold, there's a Chiari malformation on the scan, and he gets his MRI scan, and he looks pretty tight there, and he's got a 1.5, but he's otherwise perfectly fine. He plays sports, he has no headaches, he has no issues, no problems whatsoever. In fact, they were in shock when we told him this. You get the rest of the pictures, and some people would say, well, I don't know, it's upper thoracic, is it real, is it one of those idiopathic things? And at least in our shop, we would feel that was real, and we thought he would benefit from surgery. So we went ahead, did a bony decompression. We've taken the ring of C1 off here. This is his ultrasound to the right. After doing all of this, taking the outer leaf of the dura off, which takes a lot longer than just doing an open duroplasty. Didn't change the ultrasound. We said, all right, he needs a real operation. Open up. He is socked in scar. As we get down to the opening to the fourth ventricle, it's socked in scar, and we felt it would be better to put a little tube in there, what we call a stent, and then we did a dural repair and went from there. And here he is pre-op, 6 months post, 1 year, and 3 years. And you've also heard through the last 2 days, the residues of the syrinx can take time. We've had kids as long as 3 years for reasons we're not quite certain. Most of the time you see something by 6 months or even earlier, as you've heard from the folks earlier. But you do follow them, you have to see. And you can see there's tons of room up here, lots of space, and you didn't get a leak, fortunately. So what do we do with these patients? We watch them and follow them closely, and we assess them with a very thorough physical exam, neurological exam, and family history. We do a decent neuro exam. For a neurosurgeon, it's more than we normally do. We try to compete with the neurologist in that level. I think Roger's already, oh, there he is. We try to at least put you guys out of business. And we do a total spine MRI with a cine film as well. Mark Quigley's seen many of those. And if the kids are doing fine, as most of them are, we follow them up closely. If they're young and they're not the best person to talk to us, then we'll see them in 6 months just for clinical follow-up. If they're older and they're articulate and they can tell us what's going on, we'll see them back in a year. And again, education. You've heard a lot about education. Education of the parents, education of the kids, depending on their age and so forth. So everybody's on the same page what to look for. Now, as time has gone on, and you saw the data, and these kids seem to fall apart by 2.5 to 3 years, it's getting kind of old when you have somebody 5 years later, 7 years later, waiting to have the scan and being tortured all day long. We've backed off from that. And if after 3 years the kids are doing fine, we see them clinically and we tell them what to look for, but we've not been as aggressive getting the pictures. We've really backed off on that. Now, I have seen patients 7 and 8 years later that come back with new issues that they didn't have on their serial scans before. Obviously outliers, but they're definitely out there. So what is the significance of this? Is it really incidental? We try to be honest, we try to be fair about looking at patients that really had no reason to suspect they had a Chiari, but I'd have to admit they're coming in awfully quick. Something else is going on, and I'd love to get a good explanation of this. Is it an early manifestation of what's happening in the adult? And again, we do have variations depending upon the age of the patient. I think we obviously need to look at the adults. We're actually doing this now with the folks in New Jersey and trying to compare the two cohorts to see, are the adult patients presenting differently? How do they do? It's not the cleanest of science because it's not the same place and it's not prospective, but it is a start, and maybe we'll be able to jumpstart something somewhere else where they see kids and adults in the same place. And clearly we need longer follow-up. You heard that earlier from Cormac. We do need 20-year follow-up and 30-year follow-up. I'll leave that to the younger guys to do as well. What's the risk of needing surgery? I tell my parents at this point, at this time, we've seen these kids, roughly 7% of them, go on to require surgery. Now, it does seem to be dropping over time, but at least with prospective data, I think we can be fairly honest with that. If the patients have a positive family history, the tonsil below 10 millimeters, if it's a 1.5 or if it's a really young kid, I do worry about those patients, and we do track them a little bit longer, but we'll see where that takes us. And will it change over time? Will these patients come back 10 years from now and saying, yeah, I was being followed 10 years ago by Keating, and they're getting scans, but now I'm having problems? Nobody knows the answer to that. I think the million-dollar question is, why does somebody come in at 35 or 40 with a Chiari issue that they probably have had brewing for a long time? What tips them over? What's the problem there? And again, that's one of the million-dollar questions. So to conclude, certainly as we have more MRIs out there, we know they're out there, you've seen the evidence by Cormac and others, we're going to see more and more of these incidental findings. It's our job to figure out what's real and what isn't real. Prospective, longer-term studies are clearly going to be helpful, and people are working on this. We see our patients symptomatic as early as 6 months and up to 2.5 years, so that's our worry window, but we do keep an eye on these folks. And I've already told you the predisposing factors. At least 7% of these kids seem to get into trouble later on for reasons that are unknown to us. It's amazing you tell a family what to look for, and 6 months later they're telling you that child can't move his neck, he's screaming at night because of neck pain. Like, where was this happening? Why didn't this happen before? But it does happen. The presentation's variable in kids as well as adults. Maybe reflects a continuum that we're not appreciating because we haven't watched these kids long enough. Maybe reflects a different disease process. Lots of midline anomalies and comorbidities, connective tissue issues. Again, you're well aware of this stuff. What's that mean? Is it something we're not truly appreciating on a genetic level? And that's probably where the answer is. We know the syringomyelia is commonly seen, or roughly 20% of the time. And we do see rarer, but it does happen where they don't have a syrinx, and lo and behold, 2-3 years later, they've developed a syrinx. Clearly, something's going on, and you heard Dr. Batsdorf earlier. The dynamics of CSF flow are critical here, and if the flow isn't working the way it's supposed to, you can end up giving trouble. And I still think the etiology is a difference between too small space versus CSF getting out, and you can add to it pressure from above for pseudotumor. You can add connective tissue issues with skull base instability and so forth. Lots of surgical approaches. Obviously, your goal is to minimize your exposure, your complications while improving success. Intraoperative imaging, ultrasound, MRI, maybe less so, are going to be clearly big tools to help us. The complication rate is high. This isn't, I can tell you what the risks are for the complications, but something we don't talk about, and Lance just talked about a little bit, the psychological cost of operating on a patient. And at the end of it, even though you avoided them dying, you avoided strokes, but now they have the same symptoms and maybe new things 6 months later, the psychological cost of that is vastly underappreciated by the people in the medical community. And I tell a lot of families that all the time. Generally, if you're operating for the right reasons, the outcomes are good, 80% or so, but there's roughly 10% of the patients that don't either get the symptoms better or the syrinx doesn't get smaller, and it's still an issue. And again, we talked about that as well. So in the future, and this is my last slide, I think we need to get a better understanding of the physiology, the hydrodynamic features of the CSF compartments and so forth, and as we get a better idea of CSF flow, able to measure it, objective measurements that will help. We need to get a better idea of what the natural history of this is over a longer period of time. It seems to be a relatively benign issue, but I'd love to follow some of these patients 30 years later and see what they do. We need to look at CSF flow versus the volume of the posterior fossa. We're working on fast, accurate ways of looking at volumetrics that you could do in 10 seconds versus 20, 30 minutes, and that will give us more objective data. I think genetics is key in this, and you've heard, some of you have been here for a couple of years now, they're learning more and appreciating more and more down at Duke, so we'll get a better handle on this, particularly the connective tissue issues as well. And again, stratification of the different types or permutations of Chiari, as well as the appropriate treatment, are going to be critical. And obviously, it's very important to look at your failures and trying to figure out, could it have been better if I'd done something else? We always learn through our failures. So I'm going to stop there. This is a picture of King Cavalier Spaniel, which you've seen earlier, and we'll be presenting some data next year, knock on wood, on some of the experience we've had with that. So I'll stop there. Thanks.